Mechanisms of breathing, mind map. Okay, so let's basically use this mind map to recollect or remember everything about the mechanisms of breathing. Well, so we'll try and then recall the key muscles of respiration and describe their roles during inspiration and expiration, and also understand the importance of the pressures in respiration, like atmospheric pressure, alveolar pressure, intrapleural, intrapulmonary pressures, and also pulmonary pressure. We should be able to remember the lung pressure changes in pneumothorax, and the pressure and volume relationships in a single respiratory cycle too. We should be able to remember. Well, the breathing cycle, one thing that you have to know is that for every inhalation and exhalation, there are so many mechanisms that are um at work over there. So let's take inhalation, about 2.9 liters of air, and exhalation about 2.4 liters. Realize there is an automatic pause in between the exhalation and the next inhalation. So the minute volume, if you take a normal one, is around 6 liters per minute, and then I take a respiratory is like 12 breaths per minute being average, and um, realize VT is around 500 mils. So as the time goes on, the volume of air in the lungs increases or decreases depending on the phase, whether inhalational phase or exhalational phase too, and the number of seconds at which the person is breathing. So breathing is a cyclical or tidal, and consists of inspiration and expiration. So that's like the overview of the breathing cycle. Cyclical and or even tidal, and consists of the inspiration and expiration, like I said. And inspiration is actually an active process. So the main inspiratory muscles are the diaphragm and the external intercostal muscles, and there are also accessory muscles of inspiration, like the sternocleidomastoid and the scalene muscles, whether anterior, middle, and the posterior scalene muscles. But expiration is normally passive. So the um, expiration is driven by the elastic recoil of the thoracic wall, and it becomes active in respiratory disease or in strenuous exercises. And during active expiration, the muscles like the internal intercostal muscles, abdominal, recti muscles, transverse abdominis, external oblique, and internal oblique muscles play major role. And the beginning of the breathing cycle is considered to be the start of inspiration from the resting or end expiratory level, and the cycle involves a smooth transition, that is from I to E, to the pause between breaths. And the normal respiratory rate in adults is about 10 to 16 cycles per minute, and in neonates and infants, the respiratory rate is much higher. Right, so with the breathing patterns, so that there are several. It could be eupnea, tachypnea, bradypnea, apnea, um, hyperipnea, Shane-Stokes, Biots, Cosmore breathing, apneustic breathing, and so many. So let's take eupnea. Eupnea is just a normal breathing rate and pattern, and well, for tachypnea, eupnea was like what I explained, with the normal inspiratory, expiratory phases, and the automatic pause, and the inspiration phase goes on. But with tachypnea, it's increased respiratory rates, and it's caused by whether anxiety, exercise, shock, or even fever. And bradypnea is decreased respiratory rates, and of course caused by drugs, metabolic disorders, head injury, stroke, even sleep. And apnea is actually absence of breathing with it could cause in a deceased patient in head injury, even stroke. Hyperpnea has to do with the normal rates but deep respirations, more of increased tidal volumes. Yeah, so normal rates but deep respirations. That's hyperpnea. And emotional stress, diabetic ketoacidosis could lead to that. For Shine-Stokes um, breathing pattern, that one there's gradual increases and decreases in the respirations with periods of apnea. And with that, it could be seen in cases where there's increasing intracranial pressure or brainstem injury. And for Biots breathing pattern, that one there's a rapid, deep respirations or gasps with short pauses between sets. That is when there is spinal meningitis, many CNS causes, and of course in head injuries there could be this type of breathing. But with Cosmos breathing, there is both tachypnea and hyperpnea. That one normally occurs in cases of metabolic acidosis, renal failure, diabetic ketoacidosis. And for apneustic breathing pattern, that one, if there's a lesion in the brainstem, but the apneustic or apneustic, there's a prolonged inspiratory phase with shortened expiratory phase. That's how it is. So, quick recap of the thoracic cage. Is a closed compartment, of course, with bones, muscles, and it's lined with the pleura, the visceral pleura lining the lungs, and the parietal pleura lining the inside of the chest wall. And the pleura is separated by a very thin layer of pleural fluid that's within the pleural the pleural cavity. So there is intrapleural fluid, and has to do with the lubrication. So it lubricates, affecting the movement of the lungs within the cavity, and it prevents separation of the two pleura. And with the muscles of inspiration and expiration, like I said, muscles of inspiration, the principal muscles are the external intercostal muscles, and the interchondral part of the internal intercostals, which elevates the lips also, which elevates several other structures. But the main or the principal ones are the external intercostal muscles and the diaphragm. So the diaphragm actually descends, increasing the vertical dimension of the thoracic cavity, and it also elevates the lower ribs. The interchondral part of the internal intercostal muscles elevates the ribs, and that one too also has a part to play with the external intercostal muscles. But the accessory muscles of inspiration, like I said, sternocleidomastoid, which elevates the sternum, and the scalene group of muscles to anterior, middle, and posterior, which elevates the upper ribs. And also deep within, you have the pectoralis minor. But with the muscles of expiration, that's inquires breathing. Respiration results from is this a passive elastic recoil of the lungs, and deep cage and diaphragm. But with the active breathing, internal intercostal muscles, except the interchondral parts, which pulls the ribs down. Like I said, it helps in inspiration. The internal the abdominals or abdominal muscles to pull the ribs down and compress abdominal contents, preventing push up of the diaphragm. And quadratus lumborum to push down the ribs too. So in inspiration, like I said, moves upwards and outwards, while the diaphragm moves downwards, and it's an active process. Yeah. And the hemidiaphragms and external intercostal muscles are the most important in normal inspiration, and diaphragms innervated by the phrenic nerve um, causes this what I talked about. The internal intercostal muscles, the external intercostal muscles, or are of course innervated by the intercostal nerves, and the accessory muscles of inspiration. They are used under intense conditions during intense exercise in lung disease. For example, the scalene elevates the first two ribs, the sternocleidomastoid elevates the sternum, and the anterior serratii elevates the upper ribs. The volume of thorax can change in 3 dimensions: the hemidiaphragms, the upper ribs, the lower ribs. So with the hemidiaphragms, there's an increase in the vertical dimension of the thorax, and that is the bicycle pump handle effect. And with the upper ribs, there's an increase in the anterior-posterior diameter, and that is the water pump handle effect. And when it comes to the lower ribs, there is an increase in the lateral or the transverse diameter by outward rotation, and that's the water bucket handle effect. So the diaphragm is basically a thin sheet of muscle innervated by 2 phrenic nerves, which originate very high in the spinal cord from C3 to C5. So if there's a damage over there, it could lead to respiratory failure. So the main muscle of inspiration causes the diaphragm, and accounts for 75% of the change in the intrathoracic volume during quiet inspiration, and it moves down about 1 cm to 7.5 cm during inspiration, and contraction increase the vertical diameter of the thoracic cage, and the ribs move out. So let's say there's this case, there's a transection of the spinal cord above the third cervical segment. What do you think? It's very fatal without artificial ventilation, as the phrenic nerve innervates the diaphragm, and it arises from the third to fifth, and the thoracic nerve also innervates nerves T1 to T11 innervates the intercostal muscle. So if it's higher up, then of course it could be respiratory failure. But the distended abdomen and its effects, of course, if there's a distended abdomen, push on the abdominal intra-abdominal pressure will push on the diaphragm, and that will affect with the inspiration and expiration. Right, so the external intercostal muscles, like I said, they run obliquely downward and forward from rib to rib, and they are 11 pairs, and they contract. When they contract, they raise the ribs, and the diameter of the chest increases too. The ribs rotate. That's a bucket handle movement, and the volume of the thorax can change, like I said, in 3 forms. And taking all these into consideration, you realize that the increase in the vertical dimension of the thorax can easily be demonstrated with the bicycle handle effect, and that of the upper ribs, the water pump effect, and the lower ribs being the water buckets handle effect. So in pediatric thorax or neonatal, the thorax of a neonate, they are poorly developed intercostal muscles, due to lower proportion of type 1 muscle fibers, and they fatigue more easily. So in neonates and young infants, the cartilaginous ribs are horizontally aligned, and the water bucket handle effect in the adult thorax is not available. So the diaphragm is more horizontally attached, which reduces the mechanical advantage. So ventilation is more diaphragmatic, and abdominal distension, like I said, could lead to um, splinting of the diaphragm and lead to respiratory failure. So with respiration, expiration is normally passive, like I said, and the lung recall to equilibrium position is what happens during expiration. The abdominal muscles, abdominal recti muscle, is used in forced expiration. For example, in respiratory disease or intense exercise, and contraction moves the abdominal content in, and the diaphragm pushes upwards, and there's reduced in reduction in the volume of the thoracic cage. And with the internal intercostal muscles, which are also 11 pairs, they pass obliquely downward and posteriorly from rib to rib and contract. The contraction pushes the rib cage downwards and reduces the volume of thoracic cage. So when it comes to the forces in lung, you can think of the intra pleural pressure, and then all the other pressures I talked about at the beginning. But the intrapleural pressure, it's the pressure in the pleural space, and it acts to expand the lung. So it is created by a balance between the chest wall recoil and the lung recoil. And in normal breathing, it is subatmospheric, around 5 centimeters of water. Okay, so the chest wall, let's take maybe the lung in a pump, and then you take away all the pressure. You see, the lung could easily expand in a vacuum, and the walls of that vacuum flask would actually recoil. Yeah, so as it comes inwards, that's the vacuum will expand the lung outwards, and that's like the intrapleural pressure. Yeah, it expands the lungs, whilst there is also a chest recoil too. So it varies in depth. That's the intrapleural pressure, about 10 centimeters of water at the apex. That's like negative 10 cm at the apex, and negative 2.5 cm H2 at the base, and it varies during the respiratory cycle. So it varies with the phase of respiration, and the negative pleural pressure keeps the lungs open, and it prevents the chest wall from expanding. Remember, the lung in a vacuum, there will be expansion. If there's a tension in the flask, then that experiment, there will actually be a recoil. Yeah, so the lung recoil, the forces in the lung, the tension that develops in the wall of the lung as it expands, and it acts to collapse the lungs. So the overall elastic recoil has to do with the pulmonary elastic recoil plus the surface tension. It's about 50%, more than 50%. So the lung tissue itself, the collagen and elastic fibers of the lung, and the surface tension forces in the lining of the alveoli are all factors. The surface tension forces are the greatest component of lung recoil. That's more than 50% of it. So the net force when intrapleural pressure is more than the lung recoil, the lung expands. If the recoil force is more than the intrapleural pressure, the lung collapses. If the intrapleural pressure is equal to the lung recoil, then, and also if the lung recoil is equal to the intrapleural pressure, then the lung volume will remain constant. So the relevant pressures for lung mechanics You always have to remember the transpulmonary pressure. So, and transpulmonary pressure has to do with the lung volume. So the transpulmonary pressure has to do with the alveolar pressure minus the intrapleural pressure. So the alveolar pressure is the same as the um, intrapulmonary pressure. So when you subtract the intrapleural pressure, you get the transpulmonary pressure, and that's a determinant of lung volume. And when it comes to the airway pressure gradient, that one is the atmospheric pressure minus the alveolar pressure or the intrapulmonary pressure. Okay, so these are some of the pressures too that you can think of. Okay. But when you think of the airway opening pressure and you bring that into the equation, you know that the transpulmonary pressure TPP will be equal to the airway opening pressure minus the alveolar pressure or the intrapulmonary pressure, all plus the alveolar pressure minus the pleural pressure. Yeah, so we have two sides to the coin. So airway opening pressure minus the alveolar pressure or intrapulmonary pressure, all plus the alveolar pressure minus the pleural pressure. But when you combine the alveolar pressure and the pleural pressure, you get the elastic recoil pressure of the lung. Yeah, so elastic recoil pressure of the lung is the alveolar pressure and the pulmonary and the pleural pressure. And this is a pressure that is needed to stretch the lung tissue and expand the alveolar space. So the elastic recoil pressure of the lung is equal to alveolar pressure or intrapulmonary pressure minus the pleural pressure. Okay, so still on the just a quick recap on the transpulmonary pressure. You know, it's like I said, alveolar pressure minus the intrapulmonary pressure, and the pressure difference across the lung and is required to keep the lung in the inflated state. So it's a main determinant of lung volume, and change in the lung volume will be directly proportional to the change in the transpulmonary pressure. And the greater the transpulmonary pressure, the greater the lung volume. So let's say inspiration and expiration, and let's take pressures in millimeters mercury. Atmospheric pressure around 760, and with inspiration around 760 and expiration around 761, and also with the lower limits being around 740. You realize the difference between the lower limits or the curve, which is the intrapleural pressure, and that of the intraalveolar pressure will give you the transpulmonary pressures. Okay, and both the changes in the lung volume, alveolar pressure, transpulmonary pressures during normal breathing. In inspiration, it's steeper or it's wider for the transpulmonary pressure, but it's narrower when it gets to expiration, latter part of expiration. So when so the lung volume actually expands in inspiration, and the transpulmonary pressures expand, but during expiration or the latter part, realize there will be a decrease. So when the flow decreases and it's about rising, the that is in the expiration phase, the transpulmonary pressure will be decreased, also based on what we discussed too. So during normal breathing, the phase of respiration at the start of inspiration and the end of expiration, you realize the alveolar pressure is 0 and the intrapleural pressure is -5. So what will the transpulmonary pressure be? So like I said, alveolar pressure minus the intrapleural pressure, so it will be 0 minus -5, which is +5. And in mid inspiration, alveolar pressure is -1, intrapleural pressure is -7, so transpulmonary pressure will be -1 minus -7, which is +6. And at the end of inspiration or the start of expiration, alveolar pressure is 0, intrapleural pressure is -8, pulmonary pressure will be 0 minus -8, which is +8. In mid expiration, alveolar pressure is 0, intrapleural pressure is -6, so transpulmonary pressure will be 0 minus -6, which is +6. So the lung volume is proportional to the transpulmonary pressure, and the greatest or the largest transpulmonary occurs at the end of inspiration or the start of expiration, and the largest lung volume is equal to the end of inspiration or the start of expiration. So airflow is highest at mid inspiration or the mid expiration, right? So before inspiration, you realize that there's a recoil. You have this -5 during inspiration, and the lung expands, and you have your intrapleural pressure less than -5, then about 6 -8 in inspiration. So in normal respiration, inspiration is active and expiration is passive, and most important inspiratory muscle is the diaphragm, and most important expiratory muscle is the abdominal recti, and the fibers in the lung and surface tension are responsible for elastic property of lungs, and the negative intrapleural pressure keeps the lungs open and prevents the chest wall from expanding. So the normal breathing is negative breathing, pressure breathing, and we make the intrapleural pressure more negative, and this distends the lungs. But the mechanical ventilation can be positive pressure ventilation, and transpulmonary pressure is the main determinant of lung volume, right? So if in pneumothorax and you have a puncture within the lungs, making the atmospheric pressure equal to the intrapulmonary pressure, you can see what will happen. So there's a connection between the atmosphere and the intrapleural space is created, and the intrapleural pressure increases from the mean at -5 cmH2 to that of the atmospheric pressure, which is about 0. So no intrapulmonary pressure will keep the lung open, and that prevents the chest wall from expanding, and the lung collapse as the chest wall expands. And when you think of the transpulmonary pressure in pneumothorax, it falls to 0. And remember, the lung volume varies directly with the transpulmonary pressure, so no transpulmonary pressure to distend the lungs, and the lung recoil decreases to 0 as the lung collapses. So that is what happens in pneumothorax. So let's take a puncture in the chest wall. Atmospheric pressure 760, 760 in the lungs. In, let's say, traumatic pneumothorax, you have the you have 750 56 intrapulmonary pressure or transpulmonary pressure. And because now the because the intrapleural pressure now becomes exactly like the atmospheric pressure, which is 600, 760, 760, there'll be definitely be a lung collapse, yeah, at that particular site. Whilst the other side that has no issue, that one, the um there will be 760 atmospheric pressure, the transpulmonary pressure 760, and 56, which is a negative pressure, helping the lung to recoil with the 760. But then with the spontaneous pneumothorax, a hole is created, but then there's still maintenance of the negative transpulmonary pressure, and still there's a maintenance. That is if there's any intervention too. With a mechanical ventilator for positive pressure ventilation, the negative pressure ventilation and positive pressure ventilation all has to do with all these pressures that I talked about. So the positive pressure ventilation and negative pressure ventilation, let's look at it in terms of the mechanism. So with the mechanism, with the negative pressure ventilation, it mimics the natural breathing by creating subatmospheric pressure around the chest, allowing air to be drawn in into the lungs. But for the positive pressure ventilation, it forces air into the lungs using external positive pressure, and then increasing the airway pressure above the atmospheric pressure. And an example of devices for the positive airway pressure is the CPAP, like the mechanical ventilators, invasive ventilators, BiPAP and CPAP, and that's a continuous positive airway pressure. And with the negative pressure ventilation, you can think of iron lung and Kura's ventilators. In terms of airflow pattern, the negative pressure ventilation, the air enters the lung passively as the chest expands due to the negative pressure. But with the positive pressure ventilation, the air is actively pushed into the lungs through an endotracheal tube or mask. And with the physiological effect, you know that the negative pressure ventilation is more natural and does not interfere significantly with normal air pressure dynamics. But with the positive ventilation and pressure ventilation, it alters the intrathoracic pressure, potentially affecting venous return and cardiac output. And let's think of some cases like in the negative pressure ventilation. Was used for polio patients, but is rarely used today except in maybe some specific neuromuscular conditions. But for the positive pressure ventilation, is commonly used in ICU for respiratory failure and anesthesia and mechanical ventilation support. With its impact on hemodynamics, the negative pressure ventilation less affects the venous return and cardiac output, but with a positive pressure ventilation, it can reduce venous return, lowering the cardiac output and potentially causing hypotension. And with its clinical applications, the negative pressure ventilation is used in chronic respiratory insufficiency, like in neuromuscular diseases like ALS. But for the positive pressure ventilation, it's used in acute respiratory distress conditions like acute respiratory distress syndrome, COPDs, exacerbations, and post-surgical ventilation. All right, so that is it for the differences between the negative pressure ventilation and the positive pressure ventilation. We'll continue with lung volumes and capacities later.